You are listening to the Aizer Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
We're here with Nick Durso, who's our esteemed occupational therapist who focuses in hand therapy at Aizer Health.
Yes.
I've done a couple of these episodes, and this falls into the category of I have some degree of association with what you do, but not much. And many of the times where I see patients with a lot of the common conditions that I know you treat, I feel sometimes like my ability to treat them is so like rudimentary,
Right.
And we'll get more into it, but classic example, let's say carpal tunnel syndrome, and we'll get back into that. I feel as a physician, I can understand a little bit of the pathophysiology, why it's happening, the patient's demographics, maybe someone's a little bit more prone to getting it. But sometimes when I just say like splint, NSAIDs, ibuprofen and whatnot, and follow up, it feels a little bit cheap maybe. I know that there's more that can be done, and there's regimens, and really therapy is going to be valuable for them. But I just find on my end, I kind of regurgitate the same treatment protocol for a lot of different people. And that's why I appreciate what you do, because what you do is so specific and you understand the nuances of these things, where when I speak in generalities of hand therapy, splint, and NSAIDs, you're actually taking care of them in a way more individualistic way. So I appreciate that. So welcome to the Aizer Health Podcast.
Thank you. I'm happy to be here. If I could add to that, it is very helpful, though, when I get a patient coming in, let's say carpal tunnel, who was already told to get a splint, right? They're already ahead of the game. Whereas if they come into me and they don't have a splint, now we have to work on that. Do I have to fabricate it for them? Do we have to purchase one, on Amazon or pharmacy, whatever? So it helps for sure, right? They go to the doctor knows, okay, it's carpal tunnel. First step really should be splinting. So that's definitely very helpful, yeah.
Awesome. I guess and we'll get back into carpal tunnel because that's probably part of your bread and butter.
Yeah.
But on the way there, I always find it interesting when people choose routes such as occupational therapy, because I find that when you have that poster of medical professionals growing up, it's always like the nurse and the doctor, and it's very prototypical characters, but they don't have the radiology technician in there, They don't have the occupational therapist oftentimes in there as well. So what was your first exposure to occupational therapy?
My first exposure was, I was working actually as a physical therapist aide. This was after I graduated with my bachelor's degree. So working as a PT aide, and I would occasionally go into the OT side of the gym if they needed help, And I saw that OT was very, very personalized. I mean, it was hand therapy, right? And they were, sitting 2 feet across from each other at the table, for the whole 30, 45 minutes. It was just very personable. Whereas the PT side of the gym, and given this can be different in different locations, I'm not, talking bad about PT. PT is very, very important. But there would be like a patient exercising in the corner of the gym and no one was there, making sure, okay, did that exercise help? Did it make you feel better, the same, worse, right? Whereas OT, they were just face to face the entire time. So I was like, okay, I like that because you feel like you're really able to help someone. And that's when I looked more into it. And it so happened that I already, just from my bachelor's degree, had many more courses for OT opposed to PT. And then that's ultimately what made me decide to go to OT school.
If you could do like an elevator pitch for what occupational therapy is, because once again, I don't know that it has the same kind of, what's the correct word? It's not as well known as the more classic aspects of medicine and therapy.
Right.
So, and it's also a weird word, right? Like
it
occupational, what does that mean?
I've had conversations about occupational therapy where at the end of the conversation, the person would say, oh, well, with this job market, it's really important, people that have, occupational therapy, like they didn't know. They thought I would help people get jobs. Right. So occupational therapy, given it can be very different in different settings, but generally occupations are things that you do to occupy your time, right? So for one person, that can be playing the piano. Another person, that can be they're a school teacher. They have to write on the whiteboard, or even getting dressed, right? Buttoning your shirt, brushing your teeth, stuff like that. That's all occupations. So ultimately, occupational therapy is helping someone do their occupations, with less difficulty, more independence. Now that can vary, obviously, very significantly. If you're working in a school, they may be working on sensory integration or handwriting, right? Something more along the lines of what I do, working on, rehabbing someone, if they have carpal tunnel or if they've fractured their wrist or tennis elbow, stuff like that, right? If you're working in a nursing home or acute care, subacute, right? Working on getting people up out of bed so they can go walk to the bathroom, brush their teeth, bathing, stuff like that. So it really does vary pretty significantly depending on where you work. But ultimately, yeah, occupational therapy, helping people do what they need to do or want to do throughout the day.
So, what I take from that is two things. The first thing is similar to every other part of medicine where, someone can be an internist and practice internal medicine, but they could be in a hospital and be a hospitalist, or they could be in an outpatient clinic, right? And they could be in nursing homes. There's such a variety of the setting that someone practices in and how that affects what they're actually doing on a day-to-day basis. And the second thing is just once again, it's one of those fields that probably it's the misnomer of how it's labeled, right?
Yeah.
That it's super confusing for people who probably could benefit from it, because I'm sure a lot of people could benefit from it, but they assume I don't have a steady job, so I couldn't benefit from occupational therapy,
right.
Yeah. So maybe it's time for a name change for the career.
I know. We talked about it quite a bit when I was in school. It does make sense to change the name just so that people, can understand it better.
Yeah. Like physical therapy, I think everyone can get a sense of you need your physical body therapied, right?
Yeah.
It's very... people have a hard time trying to negotiate what that means when it comes to, and then really differentiating between both of them, right? Both of them seem to be involved with rejuvenating, rehabilitating, but the nuanced difference between them, I think, is probably lost. I mean, if you can have a tagline for what the difference is discretely between both fields, what would that be?
So it's tough. There's so many different sayings, for what I do, it's very, very, there's a very fine line, right? It's if you have basically an injury to your neck, back, hips, knees, ankles, you're going to physical therapy, right? If it's shoulder down to the hand, you're coming to occupational therapy. That's how it'll be in a lot of outpatient clinics, right? But there is definitely a very fine line between OT and PT, because OT can do a lot of stuff that PT can do, and PT can treat the arm just like OT can, right? So it can get a little, dicey at times, but as long as you're, close with your coworkers, then that's a good thing too, right? I can go to the PTs, ask them for help. They can come to me, ask me for help, and we kind of just understand what patient should go where, right?
Just for people who aren't necessarily aware, what is the pathway like to become an occupational therapist? So kind of starting from, I guess, most of these decisions have to be made by college, generally speaking, for requirements. What does one do so they understand the level of training that you have for occupational therapy?
Yeah, so occupational therapy is a master's degree. You can get your doctorates in it right now, but it's not required. So I got my bachelor's degree, 4-year degree in health science, right? And then from there, I had to choose, a direction. Do I want to go physical therapy, PA, OT, right? Ultimately chose OT, so that was a master's program. That was an additional 2 years of school, and then 6 months of clinicals, right? So basically working full time in 2 different locations, 3 months in each. So ultimately, you can do it much quicker than I did it. You can do a program that is just bachelor's right into the master's, around 5.5 years, right? Whereas I took the longer route because I didn't know yet what I wanted to do. But ultimately, you would need your master's, or some schools are offering doctorates now too, so you can do that as well.
Additionally, to do the hand specifically, is that another level of training, or is that just a specification that you kind of take after you're done with training that you want to focus on that?
You definitely touch on it throughout OT school, even a little bit. For me, even as a prerequisite to OT school, we had to take human anatomy with a cadaver. So we covered a lot of it in that course. But it's more so definitely after the courses. When you start the field work, if you get a field work in hand therapy, that's great, because then you're going to get great experience. If not, then you start afterwards once you start practicing.
Mm-hmm.
But for the most part, it's you can do it after you graduate. Kind of decide which direction you want to go.
I remember from medical school when we did the anatomy lab to understand the intricacies of hand and arm anatomy. And I just remember the level of complexity of the hand and how daunting it was, because you assume it's a very small space, right? So it shouldn't be terribly difficult, but the level of movement that we're afforded by how our hand is set up, it actually is very complicated, both neurologically, sensory, and motor. Yeah. And that comes into play certainly from an acute care perspective and making sure that you understand different injury patterns. Right. So for you, what is it about the hand that kind of like was the most interesting aspect?
So when I started taking human anatomy with a cadaver, there was 4 different modules, right? We did the back, then the arm, then abdomen, chest, thorax, right? Going over all the organs, and then the legs. And from when I took the course, I just found the upper extremity most interesting, right? And then after I took the course, they asked me to help be a TA for the course, right? So throughout my schooling, I worked in the cadaver lab as a TA, and that was always my favorite module. I think it's just so complex, and once you think you know it all, you realize that you don't, and there's more and more to learn always, and then there's all these different anomalies that you find, and it always just kept me very interested. But it's extremely complex, which is why I like it, right? Keep learning, keep researching, keep learning, and
When you think of the hand, I was having a conversation with a friend earlier this week who is a doctor in physical therapy, right? And he's talking about his passion in really trying to rehabilitate people. And the idea of prehabilitate people came up. I don't know if this is something you're familiar with, and I don't know if it's a term that we made up or I might be using a term that's actually out there. But so often in life, as we're going through life, we assume that some structures just proceed through life naturally without any significant intervention, everything's going to be okay. Right. But you kind of realize more nuanced fashion that if you want something to age well, you have to be cognizant, aware of it, and actually be treating it appropriately as one ages. Yeah. And I guess maybe that's where the term prehabilitation kind of came up. Obviously rehabilitation is when something devastating, something bad has occurred, and now we have to try and regain function. But in your mind, and you'll let me know if I'm completely off base, are there any ways that someone can prehabilitate their hand, right? To take good care of their hand to kind of ensure that it's lasting them throughout their lifetime?
Yeah, 100%. So I would say first thing that comes to mind is posture, right? And I'm guilty of it myself, right? Just kind of sitting on the computer, slouching over, right? But over time, something's most likely going to go wrong, right? And a lot of times it'll lead to something like a shoulder impingement, right? Mm-hmm. Someone's slouched over, forward head posture. When that happens, the muscles in the back are going to stretch out. The muscles of the chest are going to shorten because the shoulder's forward, right? That's ultimately going to lead to the shoulder blade not rotating the way it's supposed to, leading to a shoulder impingement. You reach your arm up, and your supraspinatus muscle, one of your rotator cuff muscles, is going to hit into the acromion, part of your shoulder blade, and over time that's going to start wearing down, right? It might lead to a tear, or might lead to a bursitis or something like that, right? So all of that just from poor posture over time, right? So definitely like ergonomics, focusing on good posture, regardless of what you do, and not ignoring symptoms, right? Like if something is starting to go numb, get it checked out, right? At least for myself, I know I'm aware of it, and just a few days ago, my fingers started going numb. So what did I do? I started treating it like carpal tunnel, did stretches, did some nerve glides. Now it feels fine, all right? So there's definitely a lot you can do to prevent things from getting worse. Just, try not to ignore symptoms and hope they'll go away. That's what I would say.
I love that point, because I'm extraordinarily guilty of this, as many people in life are. Doctors probably being the worst patients. I will quickly state that I had a medical episode where actually I had an episode of viral meningitis. And this was a few weeks ago. Thank God I'm back to 100%. Everything's good. And it absolutely reinforced some aspects of medicine and the importance of taking care of people in an empathic way, and really trying to listen to your patients. So there's a lot of important things that I gleaned from it. So I wouldn't say I'm happy that it happened, but I'm certainly I'm I'm happy I was able to take away meaningful points that I can kind of use in my everyday life as a clinician.
Right.
But the funny part of the story, if you can include any parts of the story, is funny. But the funny part of the story is that I knew that I probably had something relatively severe for a solid 8-9 hours before I was willing to let anyone take me to the hospital to get it assessed as I knew it should have been. But way too often we ignore symptoms that come up. And I think there's a couple of components to why we do that, right? So the first one is the absolute fear of the unknown, right? Yeah. So for someone who legitimately does not know much about medicine, you really have no idea what the downstream consequences are of complaining of a specific issue, right? Yeah. I mean, it can be a litany of tests, a litany of doctor appointments, and in our minds, it's almost easier just to let it go and hope that it goes away, and hope and pray, literally, that it goes away. Yeah. And the second point is probably that, even if we know what's going on, there's just the decision of, I don't have time to deal with this right now. Even though it's my body and this is probably over the long run a priority, I just don't, I don't have the time, right? Because we're all caught up in our personal lives. Yep. Both of those are poor frames for taking care of oneself, right? Like the fear of the unknown is reasonable, but at the same time, like, well, then let's get it known so we can take care of it appropriately. Right. And I don't have time for this is kind of like, well, if you don't have time for it now, do you have time to spend triple or quadruple the amount of time later on, because it's going to be more of an invasive, intensive therapy that's going to be required, But once again, it's just, and then sometimes there's also a belief that it can't be fixed, right? So I remember I was speaking to Dr. Mand, and he was mentioning about toe fungus, like on the toenail. It gets very dystrophic, very morphologically, it looks very different. It's yellow, it's thick. Yep. And I think a lot of people naturally assume like, oh, this is what it is from now on. It's impossible to fix this. Right. It's not true. And it is a very lengthy treatment course, but people just kind of come to a natural assumption. This is what life is at this point, you know? And we definitely all have to be better about like not ignoring our symptoms and actually getting them checked out appropriately. Yeah, I agree. Was there a moment as an occupational therapist so far that like, and I've had this as a physician sometimes, where there's just something about a particular patient encounter that is extra gratifying, that almost like confirms you're doing the right thing in your life as a practice? Yeah. Oh yeah, absolutely. I think just seeing patients get better is very gratifying, right? It's why you go into the profession, right? You want to help people. So when you hear things such as like, wow, I'm able to lift my grandbaby again, I haven't been able to do that for the past 4 months. Like it feels good to know that you helped with that. I had, in addition to working here, I also work at St. Anthony's outpatient, doing the same thing, hand therapy, right? And I had a patient who was a tattoo artist. Right, so she was completely out of work. She was like, I can't do anything, So to hear her say, to me, like, oh, I'm back to tattooing people. I'm back to work. Like, I did not think that this would be possible. I thought I was going to have to switch careers, but now I'm actually back to doing what I love. It's just such a great feeling, to know that you helped someone. What is it that keeps you motivated on a daily basis? Is there something, because I bring this up to a lot of people who've sat in that chair. Medicine, therapy, whatever it is, long work hours, sometimes it can be, the scheduling can be tough, especially if it's very tight scheduling. I find that myself, there's always idioms, phrases that I go back to that kind of reinforce in my mind the significance of what I'm doing and why I'm doing it. Is there anything that kind of keeps you motivated throughout the day or throughout the work week? I want to say I like helping, or I like trying to solve problems, right? So I like when a patient comes in and they're not responding the way that I thought they would to treatment, right? Because now that's like, of course, I want everyone to get better. I'm going to look into that. Why? What am I missing? Am I missing something? You research, you do, try and find out what's going on, is there another path that I can take? So that like problem solving, I think it's probably the biggest motivator for me, right? Like if I'll get a script that just says wrist pain, okay, great, why? So now I have to figure out why, what is it? So going through that whole battery of assessments, trying to figure out what's going on and stuff. So
to me, I like that. I like that aspect of the job, and also the creativity too. I like being able to be creative, whether that's like making splints for patients, right, or coming up with creative ways to integrate whatever it is that they're struggling to do at home. You know, mimicking that in my little office that I have, right? An example of that, and I hope I don't get this wrong, but a patient had told me that he was having trouble in the synagogue lifting up the Torah.
Yep, you're dead on so far. That's correct. Yeah,
so
it's a Herculean effort. It takes a lot of.
He said it's very heavy, and he was having trouble lifting it up, holding it up, and turning while he's holding it. So he explained it to me, right, and how, like, I guess one end of it might be heavier than the other depending on what time of, right. So
you're getting this 100% correct so far, by the way. You're doing very good, yeah.
So I grabbed 2 weighted dowels, right, like a 4-pound one and a 3-pound one, I think. So they're a different weight, and I just taped paper towel in between it, right, just so that there would be some like tension to it. And I just had him lift it off the table, stand up, turn around, stand back, do it, right, and just kind of do reps of that, and then switch hands. So now the heavier one's in this hand, and do it like that, right? So like that is something that was important to him, and I, you know, working with him, figured out a way that we can mimic that in therapy, right? So creativity, ultimately, another thing that motivates me, brings me back every day.
2 things. The first thing is that story's awesome. Actually, maybe 3 things, but that story is awesome. I guess the first question I have is he came to you specifically because it was troubling him that he wasn't able to do that?
He didn't come because of that, but that was because of the condition that he had. He was struggling to do that. So it's something that he just mentioned during one of our sessions. So I said, okay, let's work on it, right? Ultimately, that's occupational therapy, right?
So that became a goal of the therapy, was let's get you back on your feet so you can do this metaphorically and physically. That's awesome. And then I guess the second question is, and this might be useful, is what is the pathway? Because you said, like, if someone has wrist pain, they can get a script like wrist pain. And, you know, I guess often from the acute care, I'm not referring to occupational therapy. Like, what's the general pathway for someone to get to you? Because there might be a bunch of people listening that would want to see you, but how does one see an occupational therapist?
Yeah, I usually just recommend going to your primary care provider, right? And if they think that it will be helpful for you to get therapy, then they'll just give you a script for occupational therapy, right? Typically, I mean, sometimes I'll get a referral and it's for physical therapy, and I have to call the referring provider and have them switch it to occupational therapy. But for the most part, you know, the providers are aware that, you know, pretty much elbow down is like almost always OT, occupational therapy, right? A lot of shoulder patients I get, they'll come in with a PT script and we have to switch it to OT. Ultimately, though, I would just say go to your primary care provider, explain the symptoms, what's going on, right? And if they think therapy is the best course of action, then they should give you a script for occupational therapy.
Is there any advantage? I know that I spoke to Dr. Rosenberg, and he's the physical rehab physician, PM&R.
Right.
Is there any benefit, you know, because he's more aware of, I guess, a lot of the physical therapy type of maneuvers, and I think he could be more descriptive with what plan he thinks needs to happen. Any interaction with like physiatrists in general, or what's that interplay?
Yeah. I mean, he's constantly sending me patients, right? And then he'll put in the referral like what he wants me to work on, right? Which is always helpful. That's always helpful, because you know, sometimes you'll get a script that just says, again, hand pain, wrist pain.
That was signed by Dr. Gilden. Yeah, exactly.
And then it's up to me to figure out what to do, which is fine. I love doing that. But yes, sometimes it's like actually coordinating with the doctor, and even like on my end, right? Rather than opposed to just him just telling me what to do, I can contact him and say, hey, should I do this? Can I do this? Or the patient is presenting with X, Y, and Z, and I didn't expect that. Do you think that's normal? Do you want to see them again? Do you want to refer them to somewhere else? So that communication, I think, is very, very important. Yeah.
This happens in other forms of medicine. I was talking to Dr. Klein about the eyes, and even Dr. Mann about the feet. And I'm kind of curious how you see it in your daily work life here in general. Sometimes patients come in with hypertension and then, you know, or diabetes, let's say, and then they are diagnosed later with diabetic foot neuropathy, where they can't feel their feet as well. Right. And that's kind of just a side effect of having long-standing uncontrolled hyperglycemia, high blood sugar. But sometimes patients come in like, oh, I have this little sore on the bottom of my foot, or there was a rock and I didn't realize I hurt myself. And then they get diagnosed with diabetic neuropathy, and then they get, they do the finger stick, meaning that they only realize the patient has diabetes after they've had this injury that seemed a little bit out of the ordinary to the patient. Right. So it's almost like reverse medicine, where you're not finding it primarily from the blood sugar. You're finding it because there's an injury to the foot, and you have to work your way back to the blood sugar being high.
Right.
In occupational therapy, have there been any circumstances where you're like evaluating treating a patient, and all of a sudden you're just like, I do this, and I usually get outcome A, but I'm doing this now and I'm not getting outcome A, and you kind of have to refer them back up the pathway for a different diagnosis?
Yeah, definitely. I wouldn't say it happens often, but for sure, like, something I've noticed is it's very rarely just one condition, right? Like, if they're coming in with wrist pain, there's probably something else going on, whether it's elbow or finger or shoulder, right? So ultimately, there's almost always something else, that we have to address. But yeah, absolutely. I've had patients where I'll notice, something like some lumps on the arm, and they said, oh, well, so-and-so said it was probably just from the therapy. I know nothing I'm doing is causing lumps on your arm, so no, go, try and stay calm. You don't want to alarm anyone, but go back to the doctor, have them, or maybe go to a dermatologist, have them take a look at it, and it ended up being lymph nodes were swollen, right, and they had an infection. Treating someone's hand, and I noticed they had some digital clubbing, right? So that can be indicative of, some cardiovascular or respiratory issues, right? So again, just kind of referring back to the doctor, or even call the doctor and say, hey, I noticed this. Are you aware of this? Do you want them to come back and see you? So yeah, it definitely does happen. Just evaluating a patient, and you pick up on other things, and you always want to just be cautious, and refer them back to the doctor.
Yeah, I mean, I think that's the team approach of medicine. And it once again, it might go back into why patients are sometimes so hesitant to see us, is because you see one clinician, you see one physician, therapist, whatever it is, and you get referred to someone else, and all of a sudden a new clinical finding that wasn't there when the first person saw you. Right. You're either getting referred back to that first person or a third person, and it almost creates this non-congruency. It doesn't seem to go together, right? Like, if this was here, why didn't the first person see it, right? So now it almost breeds distrust in the medical system, although really what it comes down to is different specialists, different specialties are going to notice different things. And it's really, unfortunately, it's like the accumulation of those multiple different specialties finding multiple different things that sometimes you come down with a concrete final diagnosis, and it's cumbersome for sure. It's difficult. It can be frustrating and annoying. But it's kind of the byproduct of having such a specialized system. I don't know most about what you do, so I really rely on you to do it well, and then to let me know if something's off base, and same vice versa, right? So, it definitely can be a frustrating part of medicine, but it's also really, really necessary in order to make sure we're catching these small details when it comes to patient care.
Yeah, absolutely.
As far as, medicine is clearly changing, therapy, I imagine, is changing, both with technical innovation. I know that there's like new devices, medical wearable devices that are helping people. Certainly, I mean, on a simple level, we all know there's various like heart rate functions and different mobile watch devices that people can wear, can detect AFib, stuff like that. Right. And everything's changing pretty rapidly now. And I imagine the next 5 to 10 years, it's going to even look more different. So, I have a sense of what that looks like in my field, but I'm curious from your perspective in occupational therapy, what are the biggest changes? And, this is speculation, so feel free to speculate. But what are the biggest changes you kind of see are going to happen in the next 5 to 10 years?
I can see definitely getting much more technology based, right? Like as is, we have a glove here that the patient can put on, hooks up to a big screen, an iPad, right? And whatever movement they do, it's going to mimic it on the screen, and they can basically play like a game, right? So if they move their hand up, or like just say, I think one of the games is like just chopping vegetables. There's just a knife on the screen, right? So you lift your hand up, the knife goes up. Put your hand down, the knife goes down, cuts the vegetable, right? So you're getting some like visual feedback without actually having to hold a knife and do it, right? So I think there definitely technology is coming into play quite a bit. That's the first example I can think of. Yeah.
In the same vein, everyone's talking about AI and how it's changing multiple different fields, multiple different professions. I tend to believe that from a cognitive standpoint, there's a lot of benefit there. It kind of widens our brain, so to speak, with more information, a little bit more accurate, quickly at your disposal. It's not perfect. You have to watch out the source and all that kind of stuff.
Yeah.
But certainly it's going to change, I think, how diagnoses are being made and to ensure that patients are more well-informed. We're not going to get as many Dr. Googles. If any, we're going to get Dr. GBT.
Yeah.
I don't know if that's trademarked, because if it is, I'm taking it right now. No, but you're going to get a lot more people coming in who are probably going to have closer to the correct diagnosis, at least than what they previously had. Like, I feel comfortable saying when someone would put something into a Google search, you'd come up, with the most bizarre answers for what the medical situation is. And I think from my experience, it's a little bit more correct overall, not perfect with AI. So I'm just curious from an occupational therapy standpoint, what is AI going to look like? Is it going to change how you document, how you interact with patients? What do you think?
I'm sure it could change how I document. I'm sure I could even use it now to help with documentation, but I don't. But yeah, I definitely do see it playing a role. But I think for what I do, it would be better used as a way to confirm what I already know, right? Some of those things that I know this, but am I positive? Let me double check it real quick, right? Whereas you search on Google, it's going to take a while. You pull out a textbook, it's going to take a while. You look on AI, the answer pops up. It's something that you already knew, so you can trust it, right? Whereas if the answer is just wildly inaccurate, you'll know because you're familiar with that. I wouldn't use it for anything that I don't already or have never known, because then how do you know it's true, right? But yeah, I can definitely see it being useful. I just haven't started using it all that much yet, but it definitely seems like it could, even if I were to use it for giving home exercise program or something like that, I'm sure it would probably come up real quick, rather than me having to search through all these different websites to find different exercises. That might be a little more time efficient.
Yeah, definitely from a confirmation standpoint. And there are not to plug any specific brand, but there's an app called Open Evidence, which is really like a evidence-based medical AI, which tries to do a similar job to other AIs, where it tries to collate the information for you in a very palatable way, so you can kind of review something, what do I need to do if a patient has kidney stones? How do I treat their pain? And it gives you the best evidence-based approach as far as opiates and NSAIDs and all these different things to treating their pain.
Right.
But yeah, if you don't know anything about a subject and then you just throw it out into AI and take what it's saying as fact, that's probably the incorrect way to use it as a medical professional for sure.
Yeah.
But I think for the layperson, once again, on average, it's probably more correct than Google searches, certainly more correct than what you hear on the street. So I think we're moving in the right direction. I'm not sure, but I hope so. We spoke briefly about splinting. I don't know if you brought anything from a splint perspective with you.
Yeah.
This is the visual component to the episode where we'll do our best to explain it with audio, but it might be more valuable if someone's able to watch it.
Right.
If you could show us what you got
So a bunch of different splints I've made over the years, but all for different conditions, right? So it's something like this would be more so if someone had something like a boxer's fracture, right, of that the fifth metacarpal, right? So something like this, help kind of just stabilize that, whether it's post-operative or even if it's treated conservatively.
How'd you make that? Is that like a 3D printer? What is that?
No, so this is, it almost looks like a fabric. It's a roll of fabric, right? But it's a thermoplastic. So I basically just dip this in hot water in our hydroculator, and then mold it to the patient, right? And then once it dries hard like that.
That's interesting. So, from an acute care emergency medicine standpoint, we use, oftentimes if someone comes to us with a fracture, we'll make a splint out of orthoglass. Okay. This is something, but I like this because it's a little bit more it's a little bit more malleable. It's not as dense and not as thick.
Right.
This is like a cool, and it seems like it's really perfectly oriented to whoever you molded it to.
Yeah. That's the great thing about splinting, right? Is you're getting something custom made for you, whereas if you're buying something prefabricated, it might not fit correctly, right? It might not do what we want it to do. And there's just so many different things that you can do with splints. Like this one, for example, I made for a patient who was having trouble. I want to say it was their ring finger, having trouble bending their ring finger, right? So this is pretty complex. This isn't something I do every day, right? But just as an example of how complex you can get with splinting, form this to their hand, right? And then we kind of created this little device here. It's actually just like fishing wire and like a knitting or sewing reel, right?
There is no way for me to describe this through the audio. So if you didn't watch, then you didn't see it. But keep telling us about it.
Right, you put your finger in this here, and it's going to help pull that finger down, right? So if you're not able to flex at that joint, you put this in, you tighten that up, and then it's going to pull that finger down into flexion. And then you would just wear that for, say 15, 20, 30 minutes, something like that. Or you wouldn't wear this all day stretching the finger, but still, just to give an example.
So someone had a tendon issue where it was like disrupted and they could no longer bend that finger, or
so it wasn't. It was this one specifically was a joint. It was just the joint itself. It might have been a finger fracture, I think, actually, and they weren't able to bend that joint there. So this ultimately is what I created, right? Wrap around the finger, and that'll help pull the finger down. So there's splints. Something like this would be like a dynamic splint, meaning like there's a moving component to it, right?
This is a different material, or is this?
It is. That's a different material.
What kind of material is this? What's the?
I forget exactly which. The name was on the tip of my tongue. I can't remember. But it's same. It's like a hard plastic, right? It's a sheet of plastic. I cut it out, heat it up in water again, right? And then that's going to mold to the patient.
That's very cool. Now, did you have you ever done this before? You literally had to invent this for this particular patient based off their needs.
Yeah, I mean,
this whole pulley system is that.
That is the company that makes this brand material. It's actually the same company that makes this. They had this design on their website, so I kind of just followed
emulated
along
that. Sure.
Yeah. But yeah, I mean, you can always look up different, there's splinting textbooks and stuff, and you can kind of.
What I love about this is that we certainly do a lot of splinting in emergency medicine and urgent care and acute care.
Right.
It's part and parcel. Orthopedic injuries are every day. Oftentimes people ask us, because we have a good sense of prognosis, operative, non-operative. I mean, not perfect. That's why we tend to refer to orthopedists. But a lot of people ask us, is it necessary? Do I have to follow up? And it pulls on my heart a little bit because I understand the pain of changing your schedule, taking time off to get an evaluation. And especially it's like the worst when you go into an orthopedic office and they're just like, yeah, that splint's great, follow up in 6 weeks. And someone's just like, why did I come? Because I had the splint already and the doctor kind of, so it feels like there's nothing additive to their care. So I love to see this kind of stuff because it makes me feel like when I want someone to follow up with hand therapy or ortho, or specifically maybe ortho to then see hand therapy, like there's going to be added value to that my generic splint that, yes, I mold it, I take care and I take pride in it, but that's really cool. That's way more specified. And it's also, it identifies an issue that happened after the fracture, right? So I could say, it probably is going to heal well and it's not on the joint, but ultimately I don't know what it's going to feel or look like in 4 to 6 weeks. So it's great that, there's really added value to all these kind of devices.
Yeah, absolutely. I mean, a lot of the splints, you adjust them over time too, right? So I'll splint them initially in a certain position and then they gain a little more range of motion. They can get the finger a little more straight, then I adjust the splint, make it a little more straight, right? Kind of follow along with how they're progressing, and that ultimately helps them reach their goal of whatever it is, trying to bend the finger, extend the finger, whatever the issue may be.
I did want to address, common conditions that you see and treat, because I think there's a lot of value in explaining that to the audience.
Yeah.
We brought this very large
Yes.
anatomic upper extremity here, which I guess we're going to try and figure out how to utilize to the best of our ability for this part of the show, so to speak. It's
Here it is. All right.
is a nice graphic portrayal of what the muscles look like in the arm. If you're squeamish, I guess this is our disclaimer. I guess now instead of going to the video, now you have to transition to the audio, because this is for the squeamish people. You just do the audio at this point. But I do want to review, because we touched on it at the very beginning, the carpal tunnel syndrome. I think that's probably a pretty common issue that people deal with, and just so we can kind of review who has it, what causes it, what you can do about it,
Yeah. So carpal tunnel syndrome. So your carpal tunnel, everyone has a carpal tunnel, right? And that's going to be located right here, right at the wrist, the front of the wrist. Very common overuse injury, right? Or pregnant women, right? They have just overall retaining fluid, right? And this carpal tunnel, it's a very small space, right? You have 9 tendons. Tendons are what control the fingers, right? You have 9 tendons that run through that carpal tunnel, and you have your median
That's
nerve.
like the pulley system that pulls them open and closed.
Right.
Pulls them closed.
Yep. The tendon is what attaches muscle to bone, right? So the muscles are on the forearm, right? And then that turns into a tendon, ultimately goes out to the fingers to help flex the fingers, right? So you have nine tendons and the median nerve going through that carpal tunnel, and there is a little roof to that carpal tunnel. So it's a very tight space, right? So a woman who's pregnant and retaining more fluid, that space might get a little bit tighter, right? Because there's some fluid in there, and that ultimately will press on the nerve, and then everything after the nerve. I like to think of nerves as almost like a garden hose, right? If you step on a garden hose, everything after that is going to be affected, right? So we're compressing the nerve here. Everything that nerve supplies afterwards is going to be affected, which usually a typical carpal tunnel syndrome will present with numbness in the thumb, index, middle, and half of the ring finger, the half on the thumb side, right? So a lot of times patients might say, oh, my hand, when I'm trying to sleep at night, my whole hand goes numb. I say, okay, it's possible, but it's unlikely that it's your whole hand. So next time it happens, we'll do some tests, of course, some provocative tests, try and figure it out during the evaluation. But if I can't reproduce their symptoms, okay, so the next time this happens, really pay attention to it, right? Because is it your whole hand? Is it actually your palm, the back of your hand, your pinky, everything? Because if it is, then it's not carpal tunnel, right? Sometimes they'll come back to me and say, you're right, it wasn't. It was my thumb, index, middle finger, my pinky felt fine. Okay, so then now we know we're talking about the median nerve, which is the nerve that goes through the carpal tunnel, right? Sometimes they may say, oh no, it was really just my pinky, it was just this side of the hand, right? Okay, now we're thinking the ulnar nerve, right? Is it being compressed at the wrist or the elbow, right? But yeah, ultimately, carpal tunnel syndrome, you're thinking thumb, index, middle, half of the ring finger.
So when we've made the diagnosis, so once again, when I've made it in the ER, and I'm proud of myself that I've made hopefully the correct diagnosis, but unfortunately I just say, obviously if someone is pregnant, sometimes it's just taking the fluid off after the pregnancy, right. But also in general, if someone, it's more of a chronic issue, computers, right? So I tend to say, and you can correct me if I'm wrong here, that people are sitting and they don't have the correct wrist support, they're going to make it worse. So it's making sure you have good wrist support at the computer, lifestyle modification, that would be included, NSAIDs and, splinting and follow up with hand. What would be the treatment protocol that you go through?
I think that's all perfect advice. And then, definitely splinting, right? That's in my opinion, the most important thing, because typically with carpal tunnel syndrome, people notice it most at night, right? And they'll say they wake up and their hand is burning and they have to shake it out, and then the symptoms get better, right? So that's usually happening because you're either sleeping with the wrist bent, right? We sleep in all odd positions, right? You sleep with your wrist bent like this, or you sleep with your wrist extended, right? If your wrist is bent, you're putting a lot of pressure on that carpal tunnel, right? If your wrist is extended, you're now stretching that nerve, right? That nerve is traveling a further distance, a longer distance, so you're stretching the nerve. So that what the splint does is it holds you neutral, right? It holds you in this position so that you're not compressing it, you're not stretching it, it just holds it neutral. Splint is usually very effective. And then
now I have to ask on the splint. Sorry to interrupt, but because I find people have sleep apnea when they go to sleep, and some people require BiPAP, CPAP. I'm using my emergency medicine ER language. That's not. Some people have CPAP where sometimes it's nasal, sometimes through the mouth, but it can look very disconcerting when people see it, and some people don't tolerate it great, but then other people say they have the best sleep of their life. So I'm just curious from a practical standpoint, people who sleep with these wrist splints, what is it comfortable? Is it not? How does that work?
Usually not. It's usually not. Unfortunately, usually splints in general are just not comfortable, right? You're blocking a joint from moving. There's times it will be more comfortable, right? If you have like a thumb arthritis or something like that, right? And moving the thumb in any direction causes pain. Okay, well then blocking that is going to help, right? Mm-hmm. But sleeping with a wrist brace, it's not easy. And I always tell patients it's not easy, right? There might be nights where you wake up and it's just off. You just subconsciously ripped it off your hand, right? But usually I notice after like a week or so, patients get used to it, and sometimes even quicker than that, they get used to it and they start, making it the whole night wearing the splint. And I also think the benefits, once they start seeing the benefits of using it, that's kind of more motivation to keep wearing it too.
Now, are there any, because I know there's a surgical procedure that people can get that kind of opens up that tunnel a little bit.
Yeah.
What is the general pathway? Do people come to you, and does anyone fail the conservative treatment, and then you have to refer them to a hand specialist? What happens?
So that part of the reason why earlier in the podcast I mentioned, you feel symptoms, don't ignore it, right? Because the worse you let it get, the less likely it is to respond well to treatment, to conservative treatment, right? If someone comes into me and they have complete atrophy, loss of muscle of their thenar eminence, which are the muscles that control your thumb, and they're saying, I've had a numb hand for 6 years. I already know the chances that we can regain full mobility and sensation in that hand conservatively is very unlikely, right? So usually the more advanced you let the carpal tunnel syndrome get, the less likely it is to respond conservatively. And if that happens, well, typically, if there's muscle loss right off the bat, I'm going to call the doctor and see if they even want to go through a therapy, because it's just very unlikely that therapy is all that's needed at that point. They might need something more. But if they don't respond well to therapy, then we would refer back to the doctor, maybe do a cortisone injection, right? If the cortisone injection doesn't help, then surgery would be the next option. Mm-hmm. Yeah.
Staying in the hand region, de Quervain's tenosynovitis.
Yep.
What is it? Who gets it? How do we treat it?
All right. So I'm going to turn this around here. Okay. So can we see this?
You're doing a great job with this disembodied upper arm, by the way. Really tremendous job on camera.
I'm trying. All right. So this de Quervain's tenosynovitis. It's a mouthful, but it's basically when you get significant pain in this area of your wrist, right? So right kind of just before the thumb, right? And a lot of times this is going to can be overuse, right? It can be texting, using your thumbs a lot with the phone, but also new moms lifting babies, right? Because that's how you're going to lift. You're going to put your hands in the underarms, and then the pressure is going to be put on the thumbs, right? So over time, that can kind of cause some irritation in these tendons, and it can be very, very painful.
If we can actually go back to carpal tunnel, because I wanted to bring this up, there are specific tests that one can do to kind of see if they are having carpal tunnel.
Yeah.
From my understanding, the tests from a reproducibility and the likelihood of the test being positive, meaning it's not a one-to-one. It's not everyone who has carpal tunnel, the test is positive.
Right.
And if the test is negative, it doesn't mean you don't have carpal tunnel, right? So what are the tests, and on average, how many people do you see who, the test is positive, they have it, or the test is negative, but they still have it? Yeah.
So there really is like a whole battery of tests, right? And typically if you do a bunch of them, and then, age plays a role, so if they're in the right age range and they're saying nocturnal or nighttime symptoms and they wake up, shaking the hand helps improve the symptoms, those are all, key indicators that it could be carpal tunnel. But a lot of the times what I will do is to know if it's at the wrist, you want to create more pressure at the wrist, right? So these are called provocative tests, right? So you're trying to produce the symptoms. Well, ultimately, like, I feel bad because that it doesn't feel good, right? But it helps me understand, like, yes, it is carpal tunnel, or no, it's seeming like it might be something else. So one of the first things I would do is just tap. I'm just tapping right over that carpal tunnel.
That's the Tinels?
Yes, Tinels. Yep.
I had to create mnemonics in medical school for all these. So I just remember tap starts with T and Tinels, so you tap and it reproduces.
Yeah. So so again, it's not 100%, right? But usually when you hit that median nerve in the carpal tunnel, they'll feel those electric signals kind of shoot out to the end of their fingers. But that's also, you can do that really for any nerve that's relatively superficial, right? I do that a lot with the cubital tunnel too. That's your funny bone, right? If anyone's ever hit the inside of their elbow on a table and they get that jolt down to their hand, it's not so funny, right? But the way to test for that is tapping there, right? You tap, you feel, I'll feel for the ulnar nerve, find it, tap, and then if they feel those symptoms shooting down to their fingers, then it's indicative of, cubital tunnel syndrome. The first one I typically would do is like a Tinels, right? You can do a Phalen's or modified Phalen's, and that's basically just extreme wrist flexion, right? And you just have them hold that position. So we're just basically putting a lot of pressure on that carpal tunnel, hold it for up to like 60 or so seconds, and say 30 or so seconds in, they say, oh yeah, I'm starting to feel these fingers are going numb. Okay, then it's telling me that the compression site could be right here. Yeah.
And with the Quervains, it's I think the Finkelstein. I had to memorize all these things.
Yeah. So basically putting the thumb in a full palm, or a full fist, I should say, right? And then you're going to ulnarly deviate or put the pinky towards the floor.
Doesn't feel comfortable anyway.
It doesn't. Yeah, it's not.
How do you know when it's positive? Because it hurts. A lot.
When I have a patient who's positive, they almost jump out of their seat. It's so painful. Yeah. So it'll be very, very painful when you stretch those tendons that are irritated there.
Gotcha. Yeah. What's the treatment pathway for this?
For Quervains?
Beyond not lifting kids and just letting them wander on the floor for forever.
Usually splinting, right? Splinting, you want to give it, because in the acute or the early on stages, it can be very, very irritated. So you want to just immobilize it. You can do some range of motion, some exercise throughout the day, but ultimately you want it to be pain-free, right? It's not like a no pain, no gain type of thing. You want to let it rest and heal up a bit. But ultimately you want to it happened for a reason, right? So why did it happen? Was it from lifting the baby? That doesn't mean you can no longer lift your baby, but you have to modify how you're doing it, right? You don't want to put all that pressure on your thumb. So ultimately splinting, right? Some light range of motion, and then over time, once they're able to tolerate more and more, you would want to strengthen those tendons, so they're a little bit stronger and able to withstand whatever you're asking of them.
From an occupational therapy standpoint, is there any value with specifically heat or ice or like a massage or a vibratory kind of mechanism? Do you use that at all?
Yeah. Almost every session I'll use heat. And then if the patient thinks that they're going to be sore from just like the overall like massage and exercise, I'll use ice at the end of the session. Typically what I advise patients to do is, especially if we're looking to gain range of motion, I'll say start with heat, right? Start with heat. Then do your exercises, do your stretches and stuff that I'm prescribing to you to do at home, right? And then if that's a lot and you feel like you might be sore from doing that, then end with ice, right? Outside of like just educating patients on what to do at home, in terms of home exercise program, I typically will just say use what feels best, right? Some people like heat more and they think it makes it feel better, then use heat, right? Some people like ice more, then I'll say use ice, right? Ice probably doesn't do all that much if it's a chronic issue, but if you feel that it's helping the pain, then why not, right?
I'm going to use this as an opportunity for you to make a plug, actually, because you brought something up I had not mentioned earlier. How important is it when you do these exercises and routines with patients that they actually like I'm trying to teach my children piano, right? And the instructor comes once a week and they sit down for 30 minutes. And if he comes back the next week, he just says they didn't they didn't practice,
Right,
right? You
right,
can
right,
tell that
right.
nothing's really better because there was no retention, there was no practice.
Yep.
How important is it with therapy and occupational therapy? Like, you got to do your homework.
I think it's the most important thing, to be honest. Like I am always telling patients, like, I can't do magic, right? Like, I can't just put my hands on you, stretch you a few times, and then you're just better and you're good, right? Like, this happened for a reason, right? We have to fix that. We're not going to be able to fix that once or twice a week, right? Like, we have to do this every day. And the way I try and explain it is, say there's an exercise that I give you to do at home. I say do it 3 times a day, right? So 3 times a day, you do that every day, right? You're going to be doing that 21 times, right? Whereas if you come to therapy twice a week, that's 2 times, right? That's a huge difference. That's a huge difference in the number of times that you did that specific exercise, whatever it is, stretching or strengthening, right? 2 times versus 21 times, right? So it's a big, big difference. I understand, like, people have time commitments, and, you know, it's hard to cut out time, you know, 3 times a day, 2 times a day, even once a day to do these exercises. But the difference is very significant. Mm-hmm. You know, when a patient is doing their exercises regularly and they come in and I say, okay, do the tendon glides, and they just jump right to it. They don't need to see pictures of it. I'm like, okay, great. I know they're actually doing it because they memorize all those steps. Mm-hmm. I'll notice those patients progress much quicker, right? Whereas when patients are not doing it, you can tell there's a difference, right? They're not progressing how I would anticipate for them to
right.
progress. Yeah.
I think that probably hits on the point where we do a poor job with agency in Western medicine, because in some ways it seems like we fix so many problems, so patients rely on us to fix problems. You know, a classic one is if someone has hypertension or diabetes, like, we have actual medications to treat hypertension and diabetes.
Right.
But, you know, I don't think, you know, when they say a pound of preventative medicine is worth, you know, a penny of preventative medicine is worth a pound of, you know, actual medicine down the line, right? I botched line for sure the first time and even the second time. But the essence of that simply being that patients believe that we can fix a problem once it's occurred. And it's true. I mean, that's what we do in medicine. We try and take the problems in front of us, certainly in emergency medicine, and fix them in real time. But the more agency someone can take in their life and kind of, you know, tie up to the best of their ability these small issues as they arise in real time, you know, you can hopefully prevent A, from taking the medication, but B, from the sequela, the downstream effects of if one is not compliant with that medication regimen, you know, the things that can happen from that. And also just the side effects of taking medication, right? There's a lot of medication which are absolutely necessary, but unfortunately they come with side effects that are difficult, can be difficult in one's life. So the more that we can do, you know, this is like the prehab discussion, right? It's not just rehab, it's making sure you're taking care of the body every day, so that even if there is an insult to the body, so to speak, and we have to fix it, at least it's a little bit more prepared to take the treatment protocol and hopefully respond a little bit better to it. Yeah. Okay, so the next one, and I know we're running late for your schedule here because we try and do this and actually see patients in the same day, and it can be a little bit complicated, but we're gonna keep to the schedule. Lateral epicondylitis. You know, I know colloquially it's called tennis elbow. I don't know if many people watching this, if that's going to relate to them at all, but, you know, what is it? How can people tend to get it, and how do we fix it?
So, tennis elbow or lateral epicondylitis. So that's going to be when you get that pain on the outside of your elbow, right? So it's going to be like right here. You have that bony prominence on the outside of your elbow. So it's going to be where the tendons attach to that bone, right? And typically that would be from a lot of repetitive wrist extension, right? So lifting the hand up like this. That can be a tough one. That can be a very painful one. Typically, you want to avoid whatever caused it, right? So are you doing something like playing tennis? If that's the case, then we are going to want to stop, you know, for at least a few weeks, let it calm down, you know, and then strengthen the tendon and get the tendon to a point where it can handle what you're asking it to do. But ultimately, there's a few different things that I like to do. If it's really severe, and a lot of times it is, patients will come in and say, I can't even grab, I can't pick something up, you know, I can't pick up a pitcher of water to pour it, you know. If that's the case, I typically will immobilize the wrist. And the first thing the patient says is, why? There's nothing wrong with my wrist, right? The pain is here. The pain's at my elbow. I know, but the reason that this happened is because you're doing this too much. You're extending the wrist too much. You're using those muscles too much, right? If I immobilize your wrist, now those muscles that move the wrist can't work, right? So they're just basically being forced to rest, right? So that's usually one of the first things I'll do if it's really severe. And it's usually very helpful, right? Another option is something which this one there's not great evidence on it, but anecdotally I've definitely noticed that it can help patients, is something called a counterforce brace. And it's like a little strap that you put right around the elbow. So we would put it like kind of right here, make it pretty tight, but not tight to the point where it's like going to be cutting off circulation. But the idea behind that is when you're extending the wrist, the muscles that cause you to extend the wrist are in the back of the forearm, right? So all of that force is going up to that point on the lateral epicondyle, or that bony prominence outside the elbow. You put that counterforce brace there. Now that's basically like the anchor point, right? That's where the force is traveling to, rather than the injured part of the tendon closer to the bone, right? So those can be pretty helpful, but there's also, I would not recommend just going and buying one if you think you have lateral epicondylitis, because there's other things that you might actually have, something like a radial tunnel syndrome or something, and counterforce brace will actually make that worse, right? So that's something I wouldn't just say, oh, go buy it, unless if I'm confident that they have lateral epicondylitis, right?
I love the wrist example because sometimes if, let's say I'm doing an ear exam, right? So the patient's like, I have right ear pain, and I go in and I'm immediately going to left ear. Like, no, doc, it's the other ear. And usually I make a joke about how it's one for free, one off, 50% off, whatever. But, there's value, you got to, sometimes someone thinks the symptom is in one spot, but sometimes I look in, a classic example, oh, my kid's tugging the right ear. Okay, so I'm going to get to the right ear, but when I looked in the left ear already, I saw the ear infection, and it happens to be in both ears, so it's actually a bilateral ear infection. The value of being comprehensive, certainly when you're evaluating someone, then sometimes our treatment pathway is, that doesn't seem to make sense inherently, but obviously the more trained you are and the more sophisticated, it is actually the treatment modality to help them with their discomfort. So that's a funny example. I didn't actually know that. Let's quickly discuss, if you have a moment, just I don't know if the nerve gliding and trigger finger what is the nerve gliding? Is that related at all?
For trigger finger?
Well, in general, what do you do nerve gliding for? What is nerve gliding?
Nerve gliding, I would give to someone who has a nerve. I'm going to try and put this arm down real quick. Sorry. Okay, so nerve gliding would be good for any sort of compression to a nerve, right? So you would nerve glide with carpal tunnel syndrome. You would nerve glide with cubital tunnel syndrome, right? Basically, the idea behind that is you're trying to free up the nerve, right? The nerve is being pinched somewhere, so you want to get that nerve gliding. The nerve ultimately is coming from the spinal cord in the neck, right, in the part of the brachial plexus, right, and it's going to travel all the way down to its target location, right? So depending on the path of the nerve, you want to move joints certain ways to help free up that nerve, right? So typical nerve gliding for the wrist you're basically just going to extend the wrist. You're going to turn so your fingers are pointing away from you, and then you're going to pull on your thumb, right? And that is going to stretch out the transverse carpal ligament, the roof of the tunnel, right? But it's also helping that nerve glide a little bit. So that's just like a example just at the wrist, but you can do nerve flossing all the way, the whole, neck, shoulder, elbow. So now if I'm thinking, one, that the median nerve is compressed somewhere else, or I just see that they're really, irritated, and I don't think that just targeting the wrist will be enough, then I have them get everything involved, right? So that would look something like this, like you're almost like a waiter holding a tray, right? If you're like this, you can tilt your head away, and then you go out, point towards the floor, tilt your head towards the floor, right?
I went the wrong way.
So you can do that.
Yeah.
That would be more of a way to tension the nerve, right? If I were to go like this and tilt my head the other way, that's more tension because now the nerve is going a longer route. If I'm like this, it's less less distance that the nerve has to travel. So if I think the nerve is getting like the reason that you can't extend your elbow, because nerve can affect mobility, right? If the nerve is scarred up, that could affect mobility. And if we want to break that up, we want to free that up, we would do what you just did, where you go the other way, we are actually stretching the nerve, right? If it's more so the nerve is just caught up like a typical cubital tunnel or carpal tunnel syndrome, I would do more of a gliding or flossing, and that would be head going to that direction, right? Fingers pointing towards the floor, and then you go back like this, back and forth. Yeah.
Interesting.
Like yep.
I guess the last two topics I just want to discuss are the trigger finger and cubital tunnel, because I think those are probably both valuable for patients to know more about. So let's start with cubital tunnel, just because we did carpal tunnel and it sounds similar. So we'll and then we'll do trigger. We'll go with the finger at the last. But what's cubital tunnel syndrome and what do we do about it?
So cubital tunnel syndrome is so that's what I mentioned earlier, your funny bone, right? When you ever hit the inside of your elbow and you get that jolt down into your fingers. And you could actually feel it, right? If you feel that bony prominence on the inside of your elbow, and then you just go a little bit more posterior or behind that, you'll feel the nerve.
A good shocking sensation.
Yeah,
that's good.
Yep. If you tap that, chances are you'll feel it. Yeah. So cubital tunnel syndrome is an issue with the ulnar nerve, right? Whereas the carpal tunnel is going to be median nerve. This is a different nerve, right? So the ulnar nerve is going to innervate sensory-wise. It's going to innervate the pinky and then half of the ring finger, right? So if a patient comes to me and they say they're getting numbness in, this side of the hand, the pinky, the ring finger, then I'm thinking, okay, ulnar nerve, right? And then it depends where they're getting the numbness. If they're also mentioning that they have numbness in the back of their hand, okay, then that's probably coming actually a little bit more proximal, a little further up the arm opposed to cubital tunnel. But cubital tunnel typically will be a compression site at the elbow, and they'll feel that numbness and tingling in the pinky and half of the ring finger. A lot of times it'll be caused from leaning, right? You're just sitting at a desk all day leaning on the desk on your elbows, or driving and leaning that arm on the center console, right? And also elbow flexion, right? So there's a little ligament that kind of is the roof of your cubital tunnel. That ligament gets taut when you flex the elbow, right? And that creates less space in that area. So if people sleep with their arms up against their body like this, right, and they're in that elbow flexed position for a long period of time, that can cause numbness there. So if people are experiencing those symptoms, that's typically my first two ways to treat it would be, one, stop leaning on the elbows if you can. If you can't, get elbow pads, right? Get something that you actually put on your elbow, a cushion, so that when you lean on it, it's not that much pressure on that cubital tunnel, on the ulnar nerve. And two, try not having the elbow flexed, right? So if you start feeling those symptoms, it could be because you're leaning, but it could also be because you're flexed. So straighten out the arm, right? Straighten out the arm, shake it out. If you're noticing it a lot while you're sleeping, wear something that keeps your elbow straight, right? Get an elbow brace that will keep you relatively straight. If patients don't want to buy a brace, then I'll recommend roll a towel around their elbow, right, and secure it some way that will stop them from bending, right? That's usually pretty helpful.
Interesting. That's I've experienced it certainly at night sometimes. So I have to do the shake it out kind of thing. I think it's probably important to have a disclaimer too, just because we're making it sound like the diagnosis is made and it's simple, and obviously, we're talking about peripheral nerves, meaning nerves towards the extremity, and we're identifying where they're getting a little bit compressed, and it's causing these very specific signs. But obviously this is the medical disclaimer, it could happen in the neck and the cervical, right? And then it's more of a dermatomal pattern, which is when it's like shooting down the arm, and it's obviously a shooting discomfort, and those are very large nerves, and that could be from compression there. And then obviously if feels like gross motor and sensory weakness, like completely flaccid, it's not responding, that seems more central as well. That could be more indicative of something going on in the brain, and that obviously requires emergent evaluation. Just because I don't want anyone coming to you just like, hey, this arm hasn't been moving for about a week. It's like, no. We were talking about a little bit of sensory loss over here. So it's very specific after the diagnosis has been made. And that's what that's what makes it confusing, right? What makes it confusing is you have to ask all these very specific questions and test the sensory and test the motor until you get a very very focused and hopefully definitive diagnosis that it's really more of a peripheral distal, meaning further down nerve, and not something that's more centrally or located. And by centrally, we mean a spinal cord or brain. So just to finish up, because I don't want to hold you too much longer, against your will in this blue room that we have here. But trigger finger, what is trigger finger, and how does one treat it?
So trigger finger is very, very tough to treat. And typically a patient will have pain, quite a bit of pain in the finger itself, right? They might have difficulty bending the finger. It may be very stiff, swollen, but a lot of times you could actually feel the nodule. The issue is that there's a nodule within the tendon sheath, right? Like a little, think of it like a ball of inflammation, right? And that nodule is getting caught, right? So if someone bends their finger down, that nodule is passing underneath a little pulley. And then when you go to open it back up, that nodule can't pass back through that pulley, right? It gets stuck. So the person might bend down and then they can't get that finger back up. And if it's a little more severe, right? If it's more mild, they might just feel a click and it'll open up, right? But the more severe it gets, you might actually have to use your other finger to kind of pop it open, right? So usually you can feel like a little nodule here at the base of the finger. It'll be painful. Treatment-wise, it's very, very tricky, and probably one of the it's one of those diagnoses that does not get treated very well conservatively, unfortunately. What I can do and what I always will recommend is splint it, right? And I actually have an example. This is one example of a splint that I would use for it. I think I have another one. But ultimately, with trigger finger, it's going to trigger when you bend all three joints of the finger, right? You bend this joint, and this joint. If you bend all of those together, then it's going to trigger. But a lot of studies have shown if you block just one joint, if you restrict motion at just one joint, then the chances of it triggering are much less, right? So you can use something like this, right, where we're just blocking that first knuckle there, right? I can still bend at the end two joints, but I can't bend at that first one, right? And this usually is enough to stop it from triggering. Is it going to completely make it go away? Maybe, maybe not. Typically what I'll recommend is let's do the splint, wear it 6 to 8 weeks, right? Take it off when you need to, but don't bend the finger when you take it off, because when you trigger it, if you do cause it to trigger, it's like a setback, right? Yeah. You're irritating it again. So we don't want it to trigger at all, 6 to 8 weeks. Wow. And then even after that, if it's still triggering, then I would just refer back to the provider or have them go to an orthopedic for a cortisone injection. Yeah, trigger finger is a tough one.
Interesting. We're running to the end over here now. I was recently listening to a podcast, and the podcast kind of mentioned how people tend to remember things, how they started and how they ended, right? Okay. So we started strong, we're ending strong. No one's going to remember anything in between. But, if there's I guess a takeaway, a lasting message that you think would be valuable for someone, to know this one thing about occupational therapy, the tagline, what would you want someone to take away from this entire podcast? I know it's a lot. It's a lot
to take away from the whole podcast.
But what would be the one thing that you feel like the biggest misconception, the biggest thing that you'd like to correct, and it would be valuable for people to take away?
So biggest misconception I'm going to say is no pain, no gain. That seems to be a big phrase that I hear a lot here, right? No pain, no gain. If it doesn't hurt, it's not helping. In the case of hand therapy, that is very rarely the truth, right? We don't want to cause pain, right? A lot of the exercises and stuff that we're doing should be pain-free. So that's definitely a big misconception, right? And also a lot of people will think, oh, it's just a finger, right? How bad can it be? It's just a finger. It's just your pinky finger, right? Well, if you're not able to use that pinky finger, can you put your hands in your pocket, right? The pinky is responsible, the pinky and ring finger are responsible for a majority of your grip strength, right? And most of your strength during grip strength is coming from the pinky and the ring finger. These fingers are dexterity, right? This is the power portion of the hand, right? So just that little injury to the pinky finger is pretty significant, considering that. So I would say there's a few things. No pain, no gain is not a rule I like to follow. It's, some people may have gone through real significant things in their life, and another person might just be dealing with a pinky, right? But for that person, it can be very debilitating, right? So I have to treat every person like that is the most significant thing that they're dealing with right now, because it really can, inhibit their entire life, even if it's just one finger, right? So that's something I always keep in mind. And then the last thing I would say is just, I said it earlier, but don't ignore symptoms, right? Like I know as we're younger, at least for me, right, I would get, oh, my shoulder hurts today, and then in 2 days it goes away, right? But like as we age, that might not go away, right? And then your body's telling you something, right? So get it checked out, because it's always better and easier to treat the sooner that, you come into therapy, rather than coming in and saying, oh, I've had this for, 6 months, a year, 2 years. It's much, much more difficult to treat then.
Awesome. Thanks for coming in. I appreciate you joining the Aizer Health Podcast. I look forward to part 2 one day, okay?
Yes, absolutely. Right. Thanks for having me.
Yeah.